Welcome, everyone. Good morning, good evening, good afternoon. My name is Scott Canna. I am a pediatric rheumatologist and HLH enthusiast from the Children's Hospital of Philadelphia. It's my pleasure to represent the Histiocyte Society and introduce today's webinar, which I think is a real treat. So just in terms of some housekeeping, what is the Histiocyte Society? It's a nonprofit group of a bunch of physicians and scientists and other providers around the globe working on advancing knowledge and outcomes for histiocytic disorders, including HLH, LCH, rare histiocytic disorders. It says this session is hosted by the rare histiocytic disorders. That's actually not true. This is the HLH Steering Committee webinar. The rare histiocytic disorder webinar will be later on this year. In terms of housekeeping, because this is in webinar mode, you are muted. So if you're having issues with connectivity or technical issues, please put them in the chat. And try to put questions into the Q&A, and we'll try to triage things that way, but we'll try to keep our eye on both. There's your Q&A button. And you can do some triaging of your own. If there are good questions that you want to see amplified, you can press like within there. Encourage you to get to know more about the Histiocyte Society on our website and become a member. And I will plug the upcoming Histiocyte Society meeting this year in Goa, India, which I am told is an absolutely gorgeous oceanside resort town. November 7th through 9th of 24. In addition, there's a full day of education on November 6th. Registration is currently open, and if you register before the early bird deadline of August 23rd, there's reduced registration for attendees from low and middle income countries. So jump on top of that. It promises to be a good session. So, and of course, at the end of this, please complete your session survey. So now I'm going to turn the floor over to Dr. Shah and Dr. Chandrakosen, who will introduce her.
Thank you, Scott. Again, as Scott mentioned, we're thrilled to have host Dr. Nirali Shah for this webinar. Just because even before we knew this, just looking at our registration, we had 400 plus registrations for this webinar. That tells how popular Dr. Nirali Shah's talk is going to be. For those who don't know her, Dr. Nirali Shah is currently the head of hematologic malignancy section at Pediatric Oncology Branch, where she is also the Lasker Clinical Research Scholar and the NH Distinguished Scholar. She had several intramural NIH grants, including the NIH Director Award. She leads a very translational research group that works on developing novel CAR, bringing novel CAR to clinic, and also studying from in addition to the CAR construct itself, its toxicities and how to monitor these patients long-term. So today, we're excited to hear her talk about immune effector therapy and HLH-like syndrome associated with it. Thank you. Take it away.
Great. Well, thank you for that introduction, and really appreciate the opportunity to be here and speak to this group. I think that we have learned so much from you all in this process, and I think that it's going to need to be continued collaboration as we start to see this develop, especially as we make CAR T cells more potent and definitely traverse across different diseases. So with that being said, these are my primary disclosures, but most importantly, most of the data, data as it is based on experience. It's not yet evidence-based. And this is really where we need to be headed as a result of our efforts. And the overview is to discuss, what we're seeing in the context of CAR T cells, specifically CAR T cells for B-cell malignancies, but it's definitely started to be seen beyond that. And then discuss the current challenges in understanding and defining and treating these toxicities, along with the advances that we have made in this regard. So in terms of CAR T cell therapy and B-cell malignancies, you have the standard slide, but just to be sure that everybody's on the same page, it's a form of adoptive cell therapy that basically is a mechanism to overcome that inherent inhibition of the endogenous T cells to eliminate cancer cells. The idea here is that basically engineered T cells will provide enhanced specificity and efficacy to target cancer. With the CAR T cells, you don't have the MHC reliance that you do for T cell receptors, so it allows you to really direct towards the antigens, which, in our case, are typically CD19, CD22. But they also come with the co-stimulatory domain that's needed for that T cell signaling, and then subsequently the cytotoxicity. And this is typically with the 4-1BB or CD28 co-stimulatory domain, but again, this is also an evolution. Ultimately, what you end up is with a T cell that has, a CAR T cell rather, that has the functionality of a T cell with the antibody-based antigen recognition properties using that SCFB. Now, in terms of most of the talk for today, I'll be really talking in the context of cytokine release syndrome, CAR T cells targeting B cell malignancies, and the vast majority of our experience has really been in B cell acute lymphoblastic leukemia, although HLH has absolutely been seen across also multiple myeloma and non-Hodgkin's lymphoma as well. But again, to give the background on cytokine release syndrome, it really is a supraphysiologic inflammatory process seen with CAR T cell expansion. It ranges from mild to severe. In severe cases, it can be life-threatening. And the first manifestation is fever. And I describe it to patients as sort of a head-to-toe, inside-out process where it really can affect any of your organ systems. But the neurotoxicity has been particularly worrisome, and it now has a new term associated with it, which also came about several years ago, which is ICANS, or immune effector cell-associated neurotoxicity syndrome. Along with the approval for the first CD19 CAR T cell in pediatric, which was actually in pediatric ALL, which was tisagenlecleucel, there was also the concurrent approval for tocilizumab, which is, as you all know, is an anti-IL-6 receptor antibody, but came along with the approval because it has allowed us to be able to mitigate some of the side effects of CAR T cell therapy, which was essential for its broader applicability. I'm going to come back to TOCI, which is why I'm focusing on this, because I don't know that it's the right agent to use in patients who subsequently go on to develop HLH-like toxicities. Now, shifting gears from cytokine release syndrome to CAR T cells and HLH, we had our first report. So we had developed at the NIH a CD22 CAR T cell that targeted CD22. CD22 is just an alternate antigen found on B cell malignancies. And at the time, this is all an evolution of the new phase of CAR T cell therapy. It became clear that antigen loss or drop of CD19 on leukemia cells was going to be a potential problem leading to immune escape. We had a historical background of targeting CD22 with an immunotoxin agent, shifted gears to CD22 CAR T cell targeting, found that it was effective, but then really embarked on a comprehensive analysis as our cytokine release syndrome was very mild, and I'll get into a lot more of these details later. But it was this very first paper, at least, from our group that sort of said, well, look, here's cytokine release syndrome. And then you have something happening 2 weeks later, and it's just not the same. And I think that this is really important to really think about the clinical observations and how they're going to inform future practice. But along with what we were seeing, it was then HLH-like toxicities, or what someone called CAR HLH after our CD19 specific CAR T cells. And these are all case reports. Then there is HLH has variable time to onset. Then it was called macrophage-like syndrome following BCMA-directed CARs, or just HLH MAS following treatment with tisagenlecleucel. So you've now got a bunch of different CARs and a bunch of different reports, and like something is going on. And ultimately, what ended up happening right around that time, again, this is in 2021, it now has a black box warning. It's on the FDA package insert for Abecma, which is one of the BCMA-targeted CAR T cells for multiple myeloma. And it basically says HLH MAS, including fatal and life-threatening reactions, occurred in patients following Abecma, and HLH MAS can occur with CRS or neurologic toxicities. But then you're sitting here and you're like, what exactly do they mean and how are they defining it? Because this is not a primary HLH and we don't know much about it, but it was important enough that it made the FDA package insert in the label to sort of give a little bit more legitimacy to what we were seeing. We started to then take a look, and this is just a retrospective analysis across 16 papers, including the one I had previously mentioned from our site. And we said, well, what are these manifestations, to try to get a better sense of the profile? And in the context of how does it relate to what we think about for other forms of, either primary or secondary HLH? And so the blue is yes, but basically the vast majority had coagulopathies. They all had profound cytopenias. The cytopenias is absolutely multifactorial. We know that cytopenias happen in patients with underlying heme malignancies and also as a result of CAR T-cell directed toxicity. But hemophagocytosis, again, the number is smaller because it wasn't evaluated for in the majority of patients. They all had elevated ferritins, maybe some hypertension, maybe some hypotension, and this probably gets to the fact that there may be some evolution with CRS resolving and these HLH-like toxicities happening. Hypofibrinogenemia, but again, really small numbers, and infection, potentially as a result of also the multiple agents that were given to try to control this inflammatory process. Now, prior to us embarking on trying to really characterize HLH-like toxicities as sort of a distinct immune effector cell-associated toxicity, the thought was that, of course, HLH happens. It's just a manifestation of severe cytokine release syndrome. And so the Children's Hospital of Philadelphia really did a beautiful job leading some of these initial efforts as it related to the initial experience with patients getting CAR T cells, having a higher degree of toxicity. And basically what they showed is that patients with severe cytokine release syndrome, and by severe, I'm talking about grade 3 and grade 4 toxicities. At the time, the standard guidelines weren't established, but again, these are patients who have multi-organ dysfunction. They may be in the ICU, they may be requiring pressor support or intubated, so they have, end organ dysfunction to a significant degree. And they were able to use, characterization of cytokine and immune profiling to say, well, patients with severe cytokine release syndrome, they overlap with a clinical phenotype that resemble MAS and HLH. And you can see that sort of nicely highlighted here with the red and the overlap. And again, it was felt that all these cytokines are expected to be elevated in patients with HLH. Now, importantly, there are differences between CAR T cells, and I sort of alluded to this already. The CD19 4-1BB experience, especially when you go back to the very beginning with the first uses, we would allow patients to get a little bit sicker. We wouldn't intervene as early. Patients got a cytokine release syndrome severities like grade 3 or 4 much more frequently, but that allowed you to sort of explore this as well. But it was also very different from our CD22, which was also a 4-1BB co-stimulatory domain, where regardless of the disease burden, a very similar patient population, our CRS severity was just not that high. And again, it probably speaks to some intrinsic differences between CAR T cells as well. But not having as much severe CRS really allowed us to discriminate some of our findings. And so what we found with the CD22 CAR T cells, and this is sort of a nice illustration in terms of timeline. So on the x-axis is day post-CAR T cell infusion. This is the context of about 1 month. Typical cytokine release syndrome, we have interferon gamma on the left y-axis, MIP-1 alpha, IL-10, and IL-6 on the right y-axis. You give the CAR T cell infusion on day 0. A couple of days later, you have cytokine release syndrome. It correlates with an increase in your inflammatory cytokines. It comes down, patients move on and do perfectly fine. What we were starting to see is that we would have that pattern, but then something else would happen as they were improving. And so these are 2 nice examples. Again, interferon gamma on the left y-axis and those other cytokines, MIP-1 alpha, IL-10, IL-6 on the right. This is, again, a standard patient, looks very similar here, except there is a slightly higher elevation of the initial cytokine release syndrome. And what you notice, and this will come back to the point about tocilizumab, is that the IL-6 goes up and then comes down and never comes back up again. But then what you see here in this secondary phase, which is almost shifted by a week, is that you have a significant elevation and much higher than what we had the first time around of both interferon gamma as well as MIP-1 alpha here. And it's quite a bit out and stays a little bit prolonged for longer. This patient here is, again, a slightly different example. The scale is different because the interferon gamma levels were so high. But initial cytokine release syndrome, the patient responded just fine. I don't think we ever actually needed to do any intervention. And then continued to have worsening inflammatory markers, rising LFTs, rising ferritin. And then you can see here that there is quite a different pattern in terms of when you do serial cytokine profiling over time. As I mentioned, the majority of our patients had low-grade 1 or 2 CRS, and that was without, some of this preemptive intervention because we weren't doing that thing at the time. And that gets to my point is that, we typically think about cytokine release syndrome as fever, hypotension, hypoxia, and that is what is used in the definitions of cytokine release syndrome. It doesn't incorporate necessarily things like, hepatic dysfunction, coagulopathies, hyperfibrinogenemia. And so when we were seeing these patients have some of these abnormalities, they actually looked quite well. And so you're sitting here being like, well, they don't have a fever, they don't have hypotension. What the heck am I going to give them tocilizumab for? But their labs were just a hot mess. And so in terms of, then we started to really profile it. And so we had at that point about 52 patients. And we just said, well, let's just look at their clinical manifestations. At the time, and I'm going, historically to where we are right now, we called it CAR-HLH. Officially, the new consensus guidelines are calling this immune effector cell associated HLH-like syndrome, so IEC-HS. But what we sort of saw here is that, C-reactive protein, which we in the CAR T cell field often will use as a proxy for IL-6, it wasn't all that different. And we did all of our biomarker analysis actually relative to the onset of CRS. And so what we wanted to do is, there's sort of two set points. One is when you give a patient a CAR T cells and you sort of follow them. But biologically, that's really a little bit skewed because one patient may have CRS onset at day 3, another patient may have CRS onset at day 14. On average, it was day 8. And so we did all of this relative to CRS onset because we felt that that was sort of biologically more significant. And so all of these are sort of, that tells you when CRS happened, the cytokines before that, the cytokines after that. The ferritin, again, that sort of helps to define HLH-like toxicities, but I mean, it's remarkably different. I'm talking, okay, so my patients have a very high ferritin, but in like the 200,000 range at peak, compared to these patients who never had any of these toxicities. There wasn't a huge difference in temperature. These aren't patients who are having high fevers, but LDH, ALT, AST, bilies, and the triglycerides. These are not fasting, but at least we saw a little bit of a pattern there. And then we saw vast difference, but only in key cytokines. So interferon gamma, some of these had almost complete overlap, as you can see here, but MIP1 alpha, we did see elevations in IL-6. The problem with IL-6 is that it can be elevated after giving tocilizumab. So in our supplemental, we actually separated these patients out by those who did and did not get toci, and the differences in IL-6 actually go away. But then in, IL-1 beta, sorry, it keeps going back. And so you can sort of see this pattern again to say that these are different. And again, everything is set to that day 0 time point being CRS onset as opposed to CAR T cell infusion. And then, it's sort of this idea that like timing is everything. I don't want to take away from the fact that there absolutely are HLH-like toxicities in the context of severe cytokine release syndrome. That exists, we see it. But what we were starting to see was this pattern, is that CRS was resolving, and then this HLH pattern was happening, or it had fully resolved, or it was even as far out as like 3 weeks later. I will say with gained experience, and especially since our paper came out, we have now started to see delayed onset of IEC-HS as far out as like 2 months or so. And so these patterns are very distinct. And as it gets further spread out, you start to be able to really distinguish the traditional CRS from an HLH-like variant. And then in terms of, the timing and all of this, because what it comes down to is that if we don't distinguish this as a separate entity, it really challenges our ability to treat these patients. So you sort of know a little bit about my opinion about using tocilizumab. Absolutely, you use tocilizumab when you have concurrent CRS, you give steroids, you use additional agents as needed. And so, this might be that it is, this severe CRS with HLH-like manifestations. But when you have resolving and resolved cytokine release syndrome, and if your CRS has already been optimally treated, is there a role for toci and or steroids? And, it's sort of based on your clinical manifestations. is it a recrudescence of CRS? So there are patients who are going to be resolved from their cytokine release syndrome, and then it comes right back up again. In which case, if their clinical manifestations look like CRS, you treat them like CRS. But what we were starting to get, because I would get calls from these patients, is that, well, they developed, hyperferritinemia, low counts. Maybe they did or did not have a fever, and we gave, not one, but 2 or 3 additional doses of tosin. And you're sitting here and like, well, we don't know if that's helpful or needed, especially when that CRP is like stone cold normal. But 2, there's a little bit of a concern, and we have a separate paper, which I don't actually get into for today's webinar, that you can't see a peak in IL-18. And so we show this, and again, there is some data in the rheumatology space where there is a concern about tocilizumab and an impact on HLH-like toxicities. And so I think we have to be mindful of what is the indication for toci, when should you use it, but when should you not use it as well, and what other agents are in your armamentarium to be able to treat these patients. And so the goal was, can we distinguish these HLH-like toxicities from standard cytokine release syndrome? What we started to do in real time, because we had a bunch of patients who were getting all these inflammatory toxicities, and we needed to be able to treat them. And so, I've presented to you, this beautiful cytokine data. We didn't have all of that in real time. In real time, I had patients who were sick who needed to be treated, and steroids alone were not sufficient. And so we sort of reached out to our rheumatologists and said, well, we know that anakinra has been used, and we sort of really leveraged the data from what had been studied with anakinra in the setting of, patients who were critically ill, and that there was some data there. And then, of course, data from anakinra and HLH. And so this is a nice example of one of our patients who has, this CRS onset, again, high ferritins actually at that time as well. But, this was treated up front. Patient was fine. Patient was actually an outpatient. And right around, day 25, we start to see this huge elevation in transaminases. So we're talking about an ALT that peaks at around 1500, an AST that peaks at just about, 600 or so. But he's well. The ferritin is also now rebounding and going back up again after it had started to nadir. And we do his day 28 bone marrow restaging evaluation. And it's, so this is sort of the pre-treatment bone marrow. And this is a B-cell ALL patient. And so what you can see here, this is looking at CD72. He's got a lot of disease. We're talking about 70% bone marrow replacement by leukemia cells. And this is looking at TDT, which is another immunohistochemistry marker for leukemia. And this is a patient who had previously gotten CAR T cells and was CD19 negative. He had a really nice response to CAR T cells, and at the 1 month post CAR, and this is a 10 p.m. phone call that I get from my hematopathologist, because we didn't really appreciate what was going on, and they said there's active hemophagocytosis. And then we were able to say, okay, well, something is happening. This patient was in a complete remission, but had just a tiny amount of minimal residual disease, just above the 0.1%. And so we weren't inclined to use steroids because we, at that point, didn't know about the efficacy of steroids in the setting of CAR T cells, decided to use single agent anakinra. And at the 2-month evaluation, hemophagocytosis had fully resolved, and the patient had achieved an MRD negative complete remission. And so starting forward from that point, we actually amended our protocol to incorporate sort of a preemptive approach to try to prevent HLH-like toxicities, to sort of say, well, we don't need to wait until it's full blown. Let's start to treat them as soon as we start to see the ferritin going up, because we were able to start to now really discriminate these patients. And so we have just completed our accrual to this trial, and we'll be writing up those results. We ended up having a lower incidence of HLH-like toxicities overall in that sort of later phase, but we will have, I think, some nice cytokine data that emerges from this to be able to look at whether the preemptive strategy was effective or not, which is where I think the field is headed. And then, again, along that time, toxicity management was variable. Nobody really knew how to treat it. And the idea is, you don't want to give too much, you don't want to give too little. And what we were lacking is definitions. And so it was important to, both be able to go beyond tocilizumab and think about what is currently available, what was being used. in really secondary HLH, including, the favorites of anakinra, roxadustat, and etoposide. And then in terms of the biologic link to HLH, going back, again, it was a little bit underappreciated because it was just thought to be, a massive cytokine inflammatory response. But, when you think about HLH, and this group doesn't need this slide at all, but a lot of the symptoms are from excessive T cell activation and interferon gamma-mediated inflammation. There's an excessive activation of CD8 T cells. And when we see our CAR T cell expansion, at least in real time, for many of our CARs, the peak tends to be around day 14 or day 21. They tend to be skewed towards that CD8 population, and then they may shift over time. So in this case, the CAR T cells are probably appropriately triggered. But what we worry about is whether there is, a lack of cytotoxic function, at least in the patients who go on to develop CAR HLH, which would mimic some of the issues with either primary or secondary HLH. And then, of course, the overlap with the macrophages and the interferon gamma as well, linking the two. And so what we wanted to do is sort of say, well, okay, now that we've clinically characterized and we've looked at the cytokine profiling, what can we do in terms of trying to figure out our CAR T cells? So what we found was that there is higher CAR T cell expansion in those who went on to have CAR T cell or CAR HLH. The blue are the patients without HLH, the red is HLH, and this is only across patients who had cytokine release syndrome. Because importantly, if you did not have cytokine release syndrome, not only on this trial did you not have a response, but you weren't going to go on to develop HLH. So we said we have to think about the patient population that was at risk. And so we can see here is, there's not really much. And at day 7, you have both the higher expansion, a little bit of overlap, but the CAR T cells don't contract to the same degree. Again, they start off higher, they end a little bit higher, and this is in the peripheral blood. And then what you can see here, this is looking at the percentage of T cells in the bone marrow as a percent of CD3 T cells in the marrow. And those who went on to have HLH had a much higher degree of CAR T cells in the bone marrow at that time point compared. And just, looking at the medians, we're talking about 60% versus 20-some percent. Along with this, we looked at the NK cells and found that there was a relative NK cell lymphopenia in those with CAR HLH. And so again, the blue is with those without HLH-like manifestations. We give our patients lymphodepletion chemotherapy, so you would expect to have a decline at day 7. But what happens with the CAR HLH patients is they tend to start lower. Again, there is overlap, but they never recover, as opposed to this pattern that you see here in the blood. And then when you look at the NK cells in the bone marrow, again, you see a similar pattern that is reflected, but again, much lower, even though we're talking about single digits versus 15% or so. And so the thought here, and again, this is just a hypothesis at present, it's hard to really know whether it's a CAR T cell on the general cytopenias that is preventing the NK cell expansion. But the thought here is that maybe the higher CAR T cell expansion in the peripheral blood and bone marrow, the delayed contraction, and the relative NK cell lymphopenia are all playing a role together. Based on some of our findings, we actually embarked on trying to do a study where we would look at all of the CAR T cell publications and products and try to compare toxicity also by the degree of expansion. And it turns out we actually weren't able to do the project because everybody reports CAR T cells in the depth, the expansion, AUC, Cmax, whatever it is, in a completely different way. So we've now embarked on a separate project trying to standardize reporting of CAR T cells, but it starts to become really important when you're thinking about toxicities. And again, linking HLH to what we're seeing in the context of CAR T cells and the underlying pathophysiology overall. And so based on, all of this work that had been done over a series of years, it was clear that recognition is needed to improve outcomes. One might argue, well, why not just use what already exists? But these definitions simply cannot be applied in cytokine release syndrome. Our patients get fevers, our patients have refractory malignancies, they have active disease, so they have cytopenias, they have splenomegaly. fine, maybe you can look at hypertriglyceridemia and hemophagocytosis, but they're not, this isn't what we're necessarily looking at. My leukemia patients are all going to have bone marrow evaluation, but this isn't a necessarily compartment or evaluated in patients with lymphoma. And so again, some of these start to be really tricky, especially when you start to give them CAR T cells, and they're going to have elevated inflammatory markers anyways. And so this didn't work because basically everybody would have had HLH based on these criteria, or at least most of them. And then, the other thing to keep in mind is that we are talking about patients with active malignancies, and we know that there is a problem with the diagnostic criteria there as well, with a lot of the overlap. And so we felt that it really was important to try to think about CAR T cells and HLH in a sort of different light, simply because of the multiple confounders we had, either with underlying malignancy, as well as just general concerns about cytokine release syndrome and overlap. And that's when we sort of started to really think about needing to come together as a CAR T cell field. And I will say more broadly as an immune effector cell field, because as these strategies are evolving, they're being put into combination, they're being used to augment things a little bit more. It is much broader. And we wanted to think about how to identify and define these toxicities. And I will say that there were several in the HLH community that wanted to say that this is not HLH, we need to call it something different, which is why the HLH-like term became adopted to comment on the similarities, but to try to talk a little bit about the pathophysiologic differences. At the time, HLH was also not in CTCAE, and so we've worked with this group to at least try to add secondary HLH as it relates to any type of therapy-related toxicity, maybe not just even immune effector cells, but to then also use these consensus criteria to think about when treatment may be indicated and how to optimize care of these patients, to think about the broader differential diagnosis, the biology, and really try to think about what future research can be done. And so there was an urgent need. I mean, these patients were, getting pretty significant toxicities. I showed you the black box warning at the beginning. It was described as potentially fatal toxicity. So I embarked on sort of establishing this working group. It was through the American Society of Transplantation and Cell Therapy. But we leveraged expertise from other groups, including rheumatology, other oncology, other folks who deal with HLH, ICU, as well as infectious disease, to really try to work on distinguishing cytokine release syndrome from primary and secondary HLH, and to establish a diagnostic criteria, a grading schema, so that we could then also be able to do cross-trial comparisons and to develop a therapeutic approach. And so ultimately, and this is in our subsequent paper, we defined IEC-HS as a development of a pathological and biochemical features of macrophage activation, or HLH, that is attributable to IEC therapy and associated with progression or new onset of cytopenias, hyperferritinemia, coagulopathy with hypofibrinogenemia, and transaminitis. And while HLH-like manifestations are frequently seen in patients with severe cytokine release syndrome, IEC-HS is often delayed in onset and manifests as CRS is resolved or resolving. And this is our paper that came out last March. In terms of thinking about then, that differentiation, here you have your primary sort of genetic HLH predisposition, of which you're all familiar with. In our setting, it's really that you have the tumor cell, the immune effector cell, and then you have the immune effector cell activation, proliferation, cytokine release with interferon gamma as part of that already. And then that cycle of the excessive, which sort of links it to, the primary HLH, the excessive macrophage activation and cytokine release. In terms of thinking about immune effector cell clinical and laboratory manifestations, this is where, as you can imagine, we struggled quite a bit. Came up with something, and this first paper was really intended to just be a foundational approach for us to say, we need to have something, this is going to evolve over time. And I'll say that some of the challenges were really because the diseases that the patients had were so different from an underlying standpoint that things became very challenging very quickly. And so We learned very early on that patients with multiple myeloma don't have nearly the high degree of elevated baseline ferritins as patients with ALL do. And so when we back to look at our ALL patient population, I want to say the average or the median ferritin at baseline, so pre-CAR T cells, pre-lymphodepletion, they may have had post-transplant relapse, but just at baseline before we did anything, again, they would have had prior therapy and also had a lot of leukemia, was around 5,000. And so compared to the multiple myeloma, we couldn't have a cut point. The other thing that I had mentioned early on is that patients with CD22 CAR T cells had very elevated ferritin. We're talking about in a couple 100,000, but other groups weren't seeing that degree of elevations, but the manifestations of HLH were overlapping. And so it became pretty critical for us to not actually have a ferritin cutoff because of the confounders and the variability and the fact that we wanted to be disease agnostic to be able to apply this more broadly across the immune effector cell field, recognizing that especially these adoptive cell therapies going to solid tumors, their underlying inflammatory status is also going to be quite a bit different. So, this is one where we tried to put some sense of it, but it was one of those where you'll know it when you see it, but we needed something. And so we said elevated ferritin, you have to have, it has to be elevated. And or rapidly rising, and it's as per clinical assessment. It says that, the onset was with resolving CRS or worsening inflammatory response after initial improvement with CRS-directed therapy. I will say that this is absolutely what we were seeing. Now that things have evolved, we are, at least myself and my colleagues are getting called in other settings where patients are getting maybe different forms of immune effector cell therapy or their combination strategies being used, where having the predecessor cytokine release syndrome is not necessary, but the manifestations that are happening are absolutely, without a doubt, HLH-like. The hepatic transaminase elevation, the hyperfibrinogenemia, hemophagocytosis, but again, not everybody's automatically getting a bone marrow. Cytopenias, which may be new onset, worsening, or refractory, because again, these patients may have cytopenias at baseline, LDH elevations, and then other coagulopathies, biliary new onset splenomegaly, and then we sort of said, other manifestations that could be present, just based on what we were seeing. And then this is, where we struggled the most, is how do you treat it, especially when you're both trying to newly define a disease entity, but you recognize that these patients have to have some guidance. And so this was very loose. We basically said that first-line therapy should be anakinra and corticosteroids. We said if they're mild or minimally symptomatic, and I think this is really challenging, a lot of these patients, they look well. And so symptomatic becomes really challenging because it's not like, somebody's having active bleeding manifestations just as a result of, the low hypofibrinogenemia. And so again, this is where we struggled a little bit because you have to recognize, and especially as CAR T cells started to move to be a little bit more outpatient, if you weren't monitoring them on a more regular basis, you might miss when things were starting to take off. But either way, we said, start anakinra and corticosteroids, second-line therapies, if you didn't have both, to add the other one, or to increase dosing and to consider adding ruxolitinib. And the third line was, if you hadn't given ruxolitinib, to consider other alternative agents, including low-dose etoposide or emapalumab for life-threatening toxicities. But then all along the way, make sure you're thinking about other etiologies. Some of the worst cases of HLH-like toxicities that had been seen in the context of CAR T cells was also challenging because there was concurrent disease progression. So you had CAR T cells that might have been active but were insufficient to eradicate disease, someone with progressive disease. And so it's not just a CAR T cell mediated toxicity, or, we worry about infection as well. And again, there was quite a bit of variability based on timing, tolerability, and severity and rapidity of manifestations. And essentially in our first effort, this is all that we could really provide because we've needed to sort of accomplish so many different goals. We also did not address, and specifically and purposely did not address, how to stop and wean these things because it, again, was a learning process. And I will say we've learned a lot in the past year. We just had a paper that came out in Hematologica, and I've taken a few figures from there just because what we wanted to do was put a couple of cases together to think about what's that next line of therapy if steroids and anakinra are not really holding the patients at bay. And so this is a pediatric patient who developed a cytokine release syndrome following tisagenlecleucel or Kymriah, which is a CD19 4-1BB based CAR T cell construct. And basically what ends up happening, this patient has cytokine release syndrome grade 2 from the initial onset, but that quickly evolves into that, cytokine release syndrome is clearly getting better. But the patient becomes coagulopathic, has refractory thrombocytopenia, is actually quite hypertensive, and was not improving. And at that point, they're on dexamethasone, anakinra, had gotten a toci. This patient ended up getting a single dose of emapalumab at 1 milligram per kilo. It was actually just under 1 mg per kilo because they maxed out at the vial size of 100 milligrams. And they had an incredibly rapid response to this agent. And I will say that there now are ongoing efforts to try to study this and also study emapalumab earlier on to see if we can either help offset even severe CRS, but also these HLH-like toxicities. This is an example of an adult patient who got ruxolitinib and had received axi-cel, which is a CD19, CD28 CAR T cell construct. And again, this patient had cytokine release syndrome that went to grade 4, neurotoxicity, which is the ICANS that went to grade 4. And this is just a nice example of just that inflammatory hot mess, right? Everything is happening and things are moving at different times. Steroids, methylprednisone, pulse dose, anakinra, got cetuximab, which is the anti-IL-6 antibody, toci. And it wasn't until ruxolitinib was started that there started to be improvement. And so there's a couple of sort of pointers here. One, when all of this happens, and again, this was shared to talk about that severe HLH-like toxicities with a cytokine release syndrome, because we care less about the nomenclature, but you have to think about the principles of IEC-HS as you think about alternate targeted therapies. What we ultimately found in this patient shown here is all of that extensive disease burden. So this is a PET scan and everything that's black is disease. Complete remission at day 28 that was sustained at day 90. I did not pull the other slide as part of this, but what was important is that, right, when these patients have HLH-like toxicities, we think that it's also associated with a high degree of CAR T cell expansion. And the missing link right now is that especially for commercial CAR T cell utilization, the assays are not routinely available to look at CAR T cell detection. And then the concern is that the more you give, you're going to offset the CAR efficacy, and these patients really have exhausted all therapies. But even with the use of ruxolitinib and everything else this patient got, they're able to show ongoing detection of CAR T cells and with the sustained response. And so the goal here is to try to say, well, can we move some of these strategies up front and avoid all of these things, especially if they may not benefit? And then our group had the experience of using etoposide. And I will say that at least right now in the CAR T cell field, there has been a strong sentiment to just avoid it. And the reason being is that Rux, emapalumab, you're targeting cytokines, but you're not directly targeting T cells. And if you use something like etoposide, are you directly also getting rid of your CAR T cells? Now, quite frankly, that might be what you need to do, but of course, the concern is you've gotten this patient through all of this to try to have them achieve a complete remission so they can survive their cancer. How could you possibly think about getting rid of your CAR T cells altogether? And so this was, at least to the best of my knowledge, the first example where we used etoposide and were able to demonstrate that we did not eradicate CAR T cells and the patient achieved a complete remission. So in terms of the patient overall had very mild, cytokine release syndrome that was well managed. And then the IEC-HS was sort of what really started to take off. And basically what ended up happening is that this patient had a tremendous elevation in their absolute lymphocyte count. And so we hadn't really seen anything like this. So this is hyperlymphocytosis. We're talking about a white count, basically that peaked at around 40,000. And we had started to give steroids and anakinra, and like the patient's white count kept getting higher and higher. We're like, we have to do something because targeting cytokines is not really the strategy here. And so we ended up giving this patient etoposide. And what I'm showing in this flow plot, here is the blood, here is the bone marrow. At day set as day 14, the peak of the percentage of T cells that were CAR positive, this is CD22, is 72. We gave etoposide right around this time point, and then at day 28, we still have a substantial fraction of CAR T cells that are present. Because we have all of our historical data, this shows you that we still have a high degree of CAR T cells compared to others at this time point who did not get etoposide. And again, very high degree of CAR T cells in the bone marrow at both 1 month and 3 months. And so again, what we're trying to do now is sort of shift gears to really think about when you have these patients who are not responding to our standard first-line approaches, what agent makes the most sense, also in terms of what's available at your institution and what's happening with the patient. To end with the last couple of slides, we did put out there an IEC-HS grading. This has now been adopted across the CAR T-cell community to be able to standardize approach and think about being able to really compare patients across the field. And then the conclusion here really is that HLH-like toxicities do occur after CAR T cells. This is now termed immune effector cell-associated HLH-like syndrome. It can be independent of cytokine release syndrome and ICANS and or life-threatening. And based on this consensus, this identification, grading, and initial attempts to treatment approach have been developed. And what I didn't get into for today's talk is that a huge part of what we also do in our paper is talk about the essential component of supportive care. And so infectious disease consultation, making sure that they're involved, thinking about the best antimicrobial prophylaxis as you start to really up the ante on the anti-inflammatory therapy that you're giving, and looking for alternative etiologies. In terms of future directions, you have to treat your patients when they're having these side effects. We aren't going to be able to know the impact on CAR efficacy until we treat more patients. Trying to do a prospective study in this particular population is challenging. I think it's almost nearly impossible to do because not everybody's going to get it. They're getting it at variable time points. But I think where the field is focused on is trying to do preemptive CRS toxicity prevention, and maybe some of those agents are also going to have a role in helping to offset any potential trigger down the road. We need to be able to look for CAR T-cell expansion consistently. We have a few multi-center efforts where we're trying to now retrospectively go back to try to identify who did have IEC-HS, because we don't have a true incidence. What we don't know is that, we have a sense now of a little bit of the CD19 world, the BCMA, the CD22, but as you develop novel targets, they're all going to have a different interaction between the antigen, the CAR, the underlying immune environment, and how is this vary? And as you know, CAR T cells are now being used for autoimmune diseases, and what do we think about that? I think from my standpoint, disease burden definitely plays a role in terms of cytokine release syndrome severity, but we don't necessarily have that same delineation with IEC-HS, at least not consistently across all the CAR constructs. Patients with autoimmune disease, they're not going to have as much, I hope, of a B-cell burden as our patients would with leukemia, but I think it needs to be seen, especially if these are going to be late onset. And then really thinking about exploring that underlying biology. Importantly, and I think that this is sort of really critical, right? As the earliest CAR T cells were, maybe not fully functional in first generation. We have second and third generation. These are now being combined, augmented, revised, or there's other strategies where you're combining some type of immune effector cell therapy, and then after a cycle, you're giving an immune checkpoint inhibitor, and then wouldn't you know it, right after that, they develop what looks like fulminant HLH. And so there is a lot more of this being seen than I think anybody had really anticipated. And I think that we have to be mindful that increasing the potency of CAR T cells as you try to improve the efficacy, especially in more difficult to treat diseases like solid tumors, is going to be challenging. And so, we end with this figure in our paper, but there is a lot of overlap. Some of these things are happening, especially in the setting of IEC-HS. You've got secondary triggers, you've got IEC, you've got the CRS and the ICANS and the malignancy associated. And ultimately, it might be that there are multifactorial etiologies, but it really, at the end of the day, we need to get our patients through it. And so with that, I'll end. This is our working group for the ASTCT cell therapy, and it's sort of color-coded by where people came from. And I will stop there and see what questions there are, but also have a case if anybody would prefer to go through that.
I think we have enough questions that
Perfect.
that will be great. I'm gonna simulate thunderous applause from our audience, and the questions continue to stroll in from the Q&A and from the chat. So I'm actually going to start with one that just came in because I don't know, I get preference. So you may have seen this paper recently about HHV6 being maybe especially good at proliferating in CAR T preparation processes. And so can you just talk about the correlation with viral reactivation, or maybe even with viruses that get passed along as part of the CAR T prep?
Yeah, so we don't worry too much about viruses that get passed along with the CAR T cell prep. And in terms of the couple of things with this, right? So at least in the patients, I will say that we haven't been consistently looking at viral. We had in our patient cohort started to, at least in the post-transplant population, looked if they were having CMV or EBV reactivation. That isn't so much a problem in patients getting CAR T cells. Obviously, there are going to be outliers, especially in their post-transplant setting. What we've noticed, though, is when patients start getting a lot of immunosuppression, we start to see a lot more of that. But in the pre-CAR phase, as it relates to things like HHV6 and how it impacts CAR T cells and proliferation, I don't think that there is that much known. I think that paper sort of raises something very interesting as it relates to T cell proliferation overall. And I think those are exactly the type of things that we would want to understand. I mean, this is personalized therapy, right? And right now, I'm not talking about off the shelf or allogeneic. These are T cells coming from patients who are going to have often also different proliferative capacity of their T cells as well. And so not a great answer, not a lot known.
Thank you. There is another follow-up question on clinical features that are in patients who have severe hepatitis.
Yeah.
Are there any pre-existing liver conditions they're coming in with?
Yeah, so most of the patients that I had, presented, so in our setting where they're all enrolled on a clinical trial and we have criteria that they can't have substantial liver dysfunction. Now, with that being said, our eligibility allows them for patients to have up to 10 times above the upper limit of normal for hepatic transaminases, right? So I'm using things that are liver toxic, methotrexate, whatever you name. Tocilizumab has some hepatotoxicity associated with but we don't think that they necessarily have either functional liver defects because they don't have any pre-existing problems. But I don't think I think it's fair to say that probably a fair number of our patients would have had prior hepatotoxic agents. The problem is that that doesn't help you discriminate who will and will not get HLH, especially when the population is pretty similar in terms of prior therapies that they would have received. I think the one thing that is evolving that I think is a little bit interesting, particularly in the sort of the immune checkpoint inhibitor, is that there are patients who are going to have this autoimmune manifestation of hepatitis. Now that's very differently, but what's starting to be seen is when you combine that with some type of immune effector cell, you might have the cascade of two different pathophysiologies intersecting, and it becomes really challenging to know what to treat. The one thing I did not point out is that, at least in the CD22 CAR experience, the patients who did have HLH-like toxicities, there were also the patients who were most likely to be responders. You're like, okay, well, that makes sense. They had higher CAR expansion, more persistent CAR T cells, fine. But that's not consistent across all of the CARs. And there's a nice paper from the pediatric real world group where they look at patients who'd all got into sagenloglusol. And again, this is before the definition of IEC-HS, but those who had HLH-like toxicities were the ones who did the worst. Now, is it that because they also were progressive disease and had so much going on, so that it becomes really, really messy in terms of knowing the implications of this. But I'm just responding to one of the comments in the chat. I do think that the earlier you treat these patients, the earlier curtail them, the less immunosuppression you're going to need, the shorter duration of outpatient therapy, the less likely they're going to be in terms of immune reactivation. So as we've gained more experience, we started to be much more aggressive up front and not wait till it's full blown. I think before, I don't know, so you wait till there's like a telltale sign of, okay, we have to really treat this patient, it's not going to turn around. And now we're like, they're just headed in the wrong direction. Let me stomp this out before it gets any further.
Maybe I can have a quick question before Scott goes with the next. Um, you showed a lot of ferritin data, right? Like
Yeah.
massively increased ferritin and
Yeah.
also liver injury. What's the soluble IL-2R look like in these patients? Just to differentiate how much of this is primary liver injury driven ferritin, how much of this is true T cell activation driven.
Yeah. So we don't have a lot of data. It was absolutely elevated. The problem that I was left with is that we didn't consistently get it. And so the question we're left with is IL-2 elevated just in CRS? Because you've got a whole bunch of inflammation going on. And so we weren't really able to draw conclusions. We do mention that IL-2 was quite substantially elevated, but we weren't able to show clear differences and the time points were off. And so that's something we need to do moving forward a little bit more consistently.
So just to expand on the biomarker question, because I think one of the things that's a little striking is the CRS criteria are sort of very hemodynamic, centered, whereas the HLH criteria are arguably a little bit more T cell activation physiology, arguably. And so, if you build in some of the other biomarkers that we can use, not just CD25, but maybe markers of coagulopathy or netosis, or are there signs that maybe the CRS features have more to do with not just T cell activation, but maybe, the explosion of B cells? And as that tumor burden really decreases, you just get more of a pure T cell activation. And where in all of that might, coagulopathy and endothelial activation sort of fit in?
Yeah. Really, really great question. So in terms of the tumor, we actually don't see a lot of tumor lysis, even in patients with a lot of active leukemia cells. Now, tumor lysis is still very different from hypotension, hypoxemia. When I think about cytokine release syndrome, I really do come to that cytokine-mediated side effects, capillary leak, that type of thing, because what's happening during CRS is that the T cells are just starting to get activated. And I think what's happening in the later phase is that it's actually T cell driven as opposed to the activation and that inflammatory cascade that it's sort of doing. And so I think in that regard, when we think about cytokine release syndrome, it is cytokine release, and the manifestations are, with the massive production of all these cytokines, the hypotension and so forth. But most of the CAR T cell expansion happens after CRS.
Oh,
Thank
that's
you.
interesting.
There's a comment about combination rather than using one agent at a time. So
yeah, absolutely. So there have been a few studies looking at anakinra in the preemptive strategy to try to prevent severe neurotoxicity, because that's where anakinra has sort of had a lot of interest, especially based on some preclinical murine models that showed that, IL-1 was sort of associated with it. In general, those studies have fallen a little bit flat. I think probably two reasons. One, anakinra dosing is just really hard, and it was done alone. And I think getting the right dose of what you need to do when you have this massive cytokine proliferation may be particularly challenging. But some studies suggesting that you were able to maybe offset or delay maybe cytokine release syndrome, or maybe decrease it, but it's challenging. What makes some of these studies even more difficult is that our entire approach to treatment of cytokine release syndrome has changed. So you can't apply historical controls. In 2012, we were putting signs on the door that said no TOSI, no steroids. We would let our patients get to the ICU before we did anything. And now I'm like, oh, you've had fever for 24 hours. Here's your first dose of TOSI. And so when you start to be able to move from truly treatment of severe toxicity to a complete shift in paradigm to prevention of high-grade severity, that's confounded our ability to test some of these strategies prospectively. With that being said, do I think there's a role? Absolutely. Do I think it's easy to study? Not at all. And I think that's why we're trying to collect these experiences, because especially with the HLH part of it, they're not happening consistently enough to be able to do like a prospective study in a way that makes sense, which is why a lot of folks are trying to focus on CRS prevention.
Well, we're going to have to cut this discussion off somewhere. This has been a real treat, a real pleasure. Thank you so much, Dr. Shah, again, for joining us, and for sharing this really exciting new iatrogenic HLH facet, which I think really both reinforces what we think we know about T cell activation and throws everything else out the window. So it's been super exciting to listen to you. Thanks again to the hundreds of folks who have followed along. Hope some of you check out the Histiocyte Society, and hopefully some of you make it to Goa this fall.
Yeah, and I was just going to say, I know there are
Please.
a bunch of questions. Like, feel free to email me. It's very easy. It's just nirali.shah@nih.gov. But feel free to email me, and I'm happy to follow up after.
Well, that is a generous way to get yourself inbox overwhelmed.
It's okay.
You're going to have to filter mine out. Again, great hearing from you. Thanks, everyone, for joining. And good luck with your CRS patients.
Thank you so
Thank
much.
you.